Welcome, everyone, and thank you so much for coming. My name is Natalie Bodner. I'm a second-year medical student and one of the co-presidents of the Benjamin Rush Institute. Today, BRI and the Anesthesiology Interest Group are partnering to hear Dr. Keith Smith speak on delivery of medical services, a free market approach. And Thomas, I know you're in the audience, so if you'd like to unmute and say a few words.
Yeah, hey guys, I'm Thomas. I'm also an M2. I'm the VP of the Anesthesiology Group. Definitely glad to be here. Definitely lucky to have Dr. Keith present to us, or Dr. Smith present to us. So without further ado, I'll let him go ahead.
Okay, well, thank you all for having me. I'm always happy to talk to medical students. I remember how miserable that time was, even though it was a long time ago for me. So thank you for taking time away from your classes. So I'm an anesthesiologist in private practice. I started my practice in 1990. I finished my training, did pediatric and cardiac fellowship training, and came to Oklahoma City primarily to do cardiac anesthesia. I love doing pediatric anesthesia, but I thought what I would end up doing in private practice was mostly cardiac, and there may not be that much opportunity for pediatric anesthesia in private practice. And fortunately, it turned out I was wrong. So I hit the ground running in 1990, practiced in the big hospitals, took call at multiple hospitals at the same time, and did very well, stayed busy. Surgeons liked me. I gave good, efficient service. And everything seemed to be going just fine. And then in 1992, George Bush, the elder, decided, along with some folks at Harvard, that they needed to institute price controls on services that physicians provided to Medicare patients. Most of the cardiac patients that I saw and to whom I provided an anesthesia service were Medicare, probably 50, 60%. Sometimes on any given week, it could be all Medicare. So I was paid $1,100 to do for the anesthesia services needed for an open heart surgery in 1992. After this price control effort that was called RVRBS, the Resource-Based Relative Value Scale, was implemented, that payment was cut to $550. Not satisfied that they had slashed physician prices enough, RVRBS 2 came out about a year later, and the payment to me for the last open heart surgery for which I provided an anesthetic was $285. So it was about a 6-hour case, came off on a balloon pump and multiple drips, very difficult case, and the payment was $285. So fortunately, by the time that all unraveled, I had been reading enough about economics to understand that this was not personal. These were people who were sending a signal into the marketplace for how they valued the service that I provided. And I thought it was incumbent upon me to return a signal that was rational. And so I didn't quit seeing Medicare patients, I just quit filing claims. So I thought, after taxes and overhead, $285 for 6 hours work, I might have had $20 left out of that. So I just decided if it's charity, it's charity, and that's how I will approach this. So I stopped filing Medicare claims in early 1993 and never filed one after that. My pediatric practice about the same time started to grow. And so I moved away from cardiac anesthesia and just did not do hearts anymore, even though that's really what I loved to do when I came out of training. So I noticed at the same time that the anesthesiologists were having their fees cut, the thoracic surgeons, the orthopedists all the specialists were having their fees cut, the primary care doctors saw their fees go up. So this was a divide and conquer strategy. And so you had internists and primary care doctors versus all of the kind of specialists, and they had us at each other's throats. So it really was a divide and conquer. Our BRVS was welcomed by the primary care doctors for the most part, and was decried by the specialists whose fees were just cut to the bone. So having said all that, I also noticed the hospitals were doing very well. They kept building on to the hospitals. They kept adding administrators to their staff. So this picture was all wrong. The people who were actually doing the work were not being paid fairly, I didn't believe. And the administrator class was on the rise. So this caused a lot of fear and consternation all over the United States. And physicians, very afraid, what is the next cut going to look like? Full of uncertainty and doubt, began selling their practices to the hospitals. And so this is when the great move for hospitals to buy physician practices started. The hospitals never hesitating to let a crisis go to waste. There's no way they were going to let this go to waste. So they just started buying physician practices, and the physicians in the mid-90s, early to mid-90s, is when they started becoming hospital employees. There were still a lot of holdouts, and most physicians just limited the access Medicare patients had to their practice. I knew many orthopedists who just said, I'll see one new Medicare patient a week, and that's how I'm going to insulate myself from this insanity. That's even more intense now. It's very difficult for a Medicare patient, whatever their financial station is in life, to say relocate, go to a different town, and find any physician that will see them at all. And that all comes from what I'm describing happened back in 1992 with these price controls, because whenever the government divides and conquers, like they did in this case, the victors are very soon going to also be their victims. So they came down on the primary care doctors as well, and started slashing their fees not long after they had feasted on all of the specialists. So the hospitals were making a lot of money. They were buying physician practices. They would sign up with these new kind of PPO, HMO plans that paid the hospitals very, very well, and did not pay the physicians well at all, but they didn't care. They could find somebody to do the case and do the surgery, or maybe they owned that practice and they would just tell the surgeon what they were going to do and how much they were going to pay them. This was not what I signed up for. I mean, it was a mess, and it was going on all over the United States. In the old days, before there were electronic medical records, we would go to the medical records department where there were all these paper charts. And you would open up the chart to sign what you needed to sign. All the clinical information was over on the right side, and all of the financial information was over on the left side. So you could flip through and see, what are the hospitals charging? How much are these patients having to pay for this service? And that was alarming. So at the same time, the physician fees were being slashed, the hospitals were charging exorbitant amounts, and it kept going up and up. And you could see that patients were on payment plans and that people were financially being destroyed. All the while that they're being destroyed by the hospitals, all the while what they were paying Medicare, and also all of the insurance companies who followed suit, what they were paying the physicians who were doing the work was less and less. So I decided the only way I was ever going to escape this circle the drain sort of pattern was to own and operate my own institution, my own facility. And as an anesthesiologist, it made sense to me that would be an ambulatory surgery center. The reason I thought that was that pain control techniques, about the time that I finished training in 1990, acute pain control was really becoming in vogue. In 1990, I was the first one to perform an interscalene brachial plexus block for shoulder surgery. And it was scandalous. I got in a lot of trouble for it. But, I just kept showing them, these comments from this patient that had absolutely no pain after a rotator cuff repair. And I was doing femoral nerve blocks and even epidurals for cruciate ligament reconstruction, trying to keep people comfortable, epidurals for thoracic and abdominal surgery, and, working hard on acute pain control. And every time we did one of these pain control techniques, the surgeons would realize, I don't really have to keep these people in the hospital. We can send them home, or we can keep them overnight maybe and then send them home. So more and more surgeries became candidates for outpatient surgery. And that trend has continued. So I had thought through all these things, and I thought, maybe as more and more surgery is possible in the outpatient environment, that if I'm going to put myself at financial risk in the founding and ownership of a facility, an ambulatory surgery center is probably where I need to go. So Dr. Steve Lantier, another anesthesiologist who I've trained with and who I've worked with, he and I were thinking along the same lines, and we just decided we were going to walk away, and we did. We walked out of our fairly lucrative anesthesia practices in the big hospitals and opened up the Surgery Center of Oklahoma in 1997. And we did that with the idea that we could not just be medical advocates for patients, but we could also be their financial advocate, because we own the facility. We could charge them whatever we wanted to, including nothing if somebody was in a hard way. So one thing I'll add is the hospitals, the whole time they were raking in all this money, were kind of embarrassed by that. And so they created this propaganda sort of narrative that they were going broke, that they were seeing all these patients in the emergency room that weren't paying them, and that they were going broke. And to justify that narrative, they actually laid nurses off at times to make it look like they were financially struggling. They would tell surgeons, we cannot afford all of these new tools that you want to do the surgeries that are kind of new and innovative. So we decided, we were going to be state of the art. We were going to provide the best care, and we were going to tell patients what they were going to pay us for it. So we were just going to be upfront about all of the money and all the finances with patients, and we were going to provide them the best care. And we knew the hospitals were terrible. They were not providing us what we needed to do the surgeries in a proper way. And we knew they were charging a ton of money for denying us all this stuff. So we thought that was a pretty good business plan. Cheaper and better was not going to be that horribly difficult to achieve. So we opened in May of 1997. And if you do the math, you realize this coming May, we will have our 25th anniversary, which is incredible given all of the real well-coordinated attacks that have been orchestrated through the years to put us out of business. So we opened up in 1997, and in about a week after we opened, a patient called, and she had a breast mass, and she wanted to know how much it would cost for us to treat her. And of course, this is the kind of patient that we were hoping would call, but I also realized I didn't know the answer to her question. So I called a general surgeon and I said, how much do you want for your professional fee to excise this breast mass? And he said he didn't have any idea. And I said, well, you need to tell me. We have a lady on hold and she's going to hang up. So he said $500. And I thought that was pretty reasonable. That was going to take care of his pre-op visit, the surgical fee, and her uncomplicated post-op care. So I thought $500 was pretty reasonable, so I hung up on him before he changed his mind. And I knew as an anesthesiologist how long that procedure was going to take. It was going to take this guy about 30 minutes to do this surgery. And as anesthesiologists, we basically bill for our time. There's some tweaks to that, but basically I had to assign a hourly rate to my own sort of internal price meter to figure out what I was going to charge her. And I knew it would take 30 minutes, not any kind of special expertise. So I had my fee in mind. And then for the surgery center, that's basically time and materials. And I knew it was not going to take very many supplies. And I started doing all this math in my head. And then I realized she is going to want to know if she has cancer when we're done. So I called a pathologist and I asked him, how much do you want to examine this specimen? Of course, he had no idea. And I finally pinned him down. This lady's still on hold. I couldn't believe she hadn't hung up. And he said $28. And of course, those fees have gone way up since then. So I told this lady it would be $1,900 all in to get her taken care of. And she said, $1,900 for what? And I said, for everything. And she said, well, the Catholic hospital down the road from you wants $19,000 just for the facility. So after the procedure was performed, I kind of sharpened my pencil and looked at it and realized we had made a profit and we really were on to something. And this sort of 10 to 1, 20 to 1 sort of pricing difference remains today. What people are quoted by a big hospital and what eventually I launched on the website with all of our prices online, it still is the case. It's 10 to 20 to 1. And we still made money. And everyone determined their own fees, and no fees were imposed on anyone. So the word started to spread, and patients would call, and they would ask us, how much? How much for an inguinal hernia repair? How much for tonsillectomy, a laparoscopic cholecystectomy, you name it. And I would quote these fees after I went through the exercise we just went through, surgeon, anesthesia, time and materials for the center, added up. And then one day, one of my front office staff called and said, we have a patient on the phone who needs a breast mass excision. How much? And I said, well, aren't you writing these down? I mean, you ought to be able to quote them without even checking with me. So we sort of populated this list of procedures to which was attached all-inclusive bundled pricing. Well, we were very successful. We saw a lot of patients come to see us that either did not have insurance or they had high deductibles, in which case the entire all-in bundled price at our facility was less than their deductible. So they would just pay us directly. There were patients with health savings accounts who paid us directly. We filed insurance claims all this time as an out-of-network facility because none of the insurance companies would work with us. We wouldn't understand that until later. You'd think, cheaper and better, more efficient. You would think the insurance companies would be all over that. They wanted nothing to do with us. And I'll explain that in a little bit. So we were wildly successful. Our pediatric practice was very successful and there are not a lot of anesthesiologists in private practice who really enjoy doing pediatric anesthesia. Dr. Lantier, he and I happen to be two that are. We love it. So, you take care of someone's child and, when they need their knee arthroscopy, they want you to do their anesthetic. What surgeon should I see? So we found ourselves, being the ones who recommended the surgeon, which surgeon should I see? And they would call us first. So things went well. We took care of all the Division I athletes in the state of Oklahoma, except for Tulsa University, but all the Division I athletes. Lots of people wanted us to anesthetize their children when they had surgery. We were very, very busy. And so we were attacked. The insurance companies, the hospitals, the health department, they came at us hard, and they did it through the legislature. So, whenever you can't compete with someone, what do? I mean, you run to the lawmaker and try to legislate your competitor out of business. And that went on. That went on for a while. And all of the attempts to attack us backfired, and just wound up putting us in an even stronger position. One decision we had made when we started was that we would never accept a dime of money from the government. And so whenever I would look at a legislator, they realized I didn't want anything from them. I didn't want any money from the government. I wasn't there with my hand out, begging for some greasy favor. I just was saying, just leave us alone and we will provide care at a reasonable price or even free to people who are in need, who just don't hamstring us. Well, everything went well until the insurance companies and the hospitals stumbled on a way to really hurt us. And what they did is they stacked deductibles on patients who had insurance. So we were out of network, and we would perform a surgery and file an insurance claim, and the insurance company would pay us after their deductible had been met. What they did is they told patients, if you go out of network, you don't have any insurance benefit unless you meet your in-network deductible first, and then you have to meet your out-of-network deductible as well. So they basically doubled the deductible penalty on patients who went out of network. And our waiting room emptied. Patients just vaporized because they couldn't financially afford to pay their deductible twice before they came to see us. And so we were really in trouble. I mean, we didn't have much business. We had grown so much that we decided to build the facility that we now occupy. It's over 30,000 square feet. It's a beautiful 7 operating room ASC with overnight beds. It's a great facility, but now we didn't have any patients. So I'd read about economics and I thought, man, if you're cheaper and better, my God, this is America. We should have a line around the block. But there was something wrong. Cheaper and better didn't matter. We had no patients. No insurance companies would work with us. And so I decided I was going to launch a website and put all of our prices online out there for everyone to see. We already had a pretty good list going, as I mentioned, from just quote over the phone. But then I called the surgeons in and I said, let's make a more complete list. So we started through the process, and I would ask a surgeon, how much do you want to be paid for your professional fee for fill in the blank? Cochlear implant, knee replacement, hip replacement, you name it. Then I would figure out, how long is this procedure going to take, figure out the anesthesia charge from there, and then time and materials, figure out the surgery center side. So I launched the website in 2009, and the weirdest thing happened. Canadians started to show up. Now, keep in mind, these are individuals who have insurance coverage, whatever that means, but they just didn't have access to the care that so many of them needed. We're seeing a lot of Canadians now because their system is completely overwhelmed and so inefficient, and everybody's employed, so really no one has any incentive, and none of the people care. I mean, it's just, they're not really their patients. It's just it's a bad government system. So these Canadians started showing up, and then these uninsured folks started showing up, and then uninsured people from other states started to show up. And we started to have a good patient flow again through our surgery center. And then one day, I received a call that there was this company that was self-funded that wanted to talk. Well, you'll hear this again. Self-funding means that you have a company that has, let's say, 100 employees, and they've decided they're not going to pay Blue Cross premiums anymore for the health benefit for their employees. Instead, whatever money they were going to send Blue Cross, they basically send to themselves in another account. That account then is used to pay all of the medical bills for the employees. So that's what self-funding is, where a company pays for its employees' health bills out of operating revenue rather than send the money to United or Cigna or Aetna or one of those yahoos to pay the bills for them. So if you think through that, that means the self-funded company has sticker shock. They care that a tonsillectomy at our facility is $2,950, not $13,000, $18,000 at the local so-called not-for-profit hospital. So the self-funded companies really got interested when I put the prices online, and they started to show up. So we now have over 300 contracts with self-funded companies who pay all of the bill. They pay 100% of the bill if the patient chooses Surgery Center of Oklahoma, including all of the travel costs. We now are not alone. There are facilities that have copied us, and so there are now multiple facilities where self-funded employers will say, if you will go there where they have their prices posted, we'll pay the entire bill. So our business continued to grow with the uninsured, the health sharing ministries like Samaritan, Christian Healthcare Ministries, Sedera, Medishare. They love us because they have sticker shock too. So, we've launched this website, and, one of our real goals had been achieved. The uninsured and the people with sticker shock were able to find us much more easily with the website. One of my other goals from launching the website was to start a price war. And people started using our prices, and I encourage this. People started using our prices to leverage a better deal in their hometown, so they wouldn't have to travel to Oklahoma City to have their surgery. One of the most insane stories is the fellow in Georgia who was told he would need to pay $40,000 for a urologic procedure we had listed on our website for $3,600 all in. And so he told his urologist, I'm flying to Oklahoma City to have this done. Well, we had picked the pocket of this urologist a couple of months before. Another one of his patients had come to Oklahoma City instead of staying with him. So he got on the horn, angry with the hospital, said, you're killing me. And so they matched our price. And the patient stayed in Georgia and had his surgery. And he later remarked to me that we had saved him $36,000 and we hadn't even performed the surgery. So this price war had started, and people started using our prices to leverage better deals. People who were being sued by hospitals for non-payment in bankruptcy court were using our prices and putting our prices in front of a jury so that they could see that these patients were just being fleeced. They were the victims of a hospital financial drive-by shooting because they could see that, this patient is being charged $100,000 and this surgery center has their price online. It's like $6,200. Are you kidding me? So our prices were being used. This price war had begun. Patients with sticker shock were finding us more often. And one of my other goals when I launched the website was to better understand what was going on. Why doesn't cheaper and better win in this industry? And it turned out that just a slip of the tongue by a hospital administrator led me down the path to understand why wouldn't an insurance company want cheaper and better. So when we were being attacked by these legislators and by these hospitals and insurance companies, I was invited to speak occasionally on our behalf. At one of these gatherings, a normally tight-lipped hospital administrator lost his cool. And he asked me what percentage of our business and our revenue was uncompensated care. And his question was meant to devastate me and the arguments I was making. And to be fair, his question confused me because I thought, how can uncompensated care be a revenue item? I mean, normally a normal person would think uncompensated is care that you provide for which you're not compensated. But that wasn't what he was asking. He asked what percentage of our revenue was uncompensated care. So I started doing some digging, and I had to dig pretty hard. And I discovered that uncompensated care is indeed a revenue item. That is what is also called disproportionate share hospital payments. And then it all became clear. So hospitals would charge $100,000 for a procedure. Let's just round numbers. Insurance company pays them $20,000. The hospital then claims that they lost $80,000. This red ink helps maintain the fiction of their not-for-profit status, which means they don't pay tax. Not-for-profit doesn't mean they're not making profits. Not-for-profit means they don't pay tax. That's all it means. So they need all of these fictional losses. This $80,000 they didn't collect was a loss. They need that red ink to cover up how much money they're making. Keep in mind, the $20,000 they're paid by the insurance company is multiples of the price I have listed online. Typically, procedure we do at our facility, 3,000 or 4,000 is one a hospital would charge 20 or 25,000 for. So that's one reason. That's one of the scams that's at work. When the hospital claims they've lost 80,000, every time they claim one of these losses, they send that information to the thugs in Washington, D.C., who then kick back to that hospital a percentage, kind of a kickback to the extent that they claim these losses. That's disproportionate share hospital payments. And they do that by padding the Medicare payments for the future year. So none of this is discoverable on the current books, and there's a reason for that. So why would the insurance companies go along with this? Well, the insurance companies ride it on their white horse to, say, a self-funded employer and say, listen, we have this $100,000 bill, and we used our muscle to negotiate it down to discount it. That's the key word, down to $20,000. So we have saved you $80,000. Keep in mind, all of these payments are pre-negotiated. The hospital and the insurance company had already agreed before this procedure ever happened that $20,000 was going to be the payment. So there actually is no discount. The discount is fictional. But the insurance companies then, claiming that they saved an employer $80,000, collect a commission based on that discount achieved. So when you think through that, you think, wait a minute, if I put my prices online, that's an opportunity foregone. No insurance company is going to be able to collect on a discount achieved when what I charge and what I am going to be paid is exactly the same thing. So this whole scam is called claims repricing. And that is why the insurance companies go along with this. So no insurance companies want to work with us. The hospitals hate us. The hospitals have been exposed. You know, when the price that I have listed online is 1/10 of what a so-called not-for-profit hospital is actually paid by an insurance company, everybody knows something's up. So the good news is this movement is growing, and these price gougers are increasingly exposed. And the whole idea of physicians owning and controlling the facilities where they work and being honest and transparent about pricing, this movement has grown. And it's grown so big that now there are actually laws that supposedly force hospitals to say, here is what we do and here's how much it is. So In 2009, when I was declared insane and people put a tinfoil hat on my head for posting prices, we've come full circle now. Now you get in trouble if you don't let people know how much a procedure is going to be. So this is reason for optimism. It's reason for everyone that's listening to me tell this story to be optimistic. I think that more and more not just the medical, but also the financial care of patients is going to be back in physician hands where it belongs, which allows us to better take care of patients and not have some goon in a $2,000 suit telling us what we can and can't have in order to provide care. So I will stop there, I think, because there may be some questions. I see there's already one in the chat room. Oh no, somebody just posted our website.
Yes,
Yeah, I'm happy to take questions.
Thank you, Dr. Smith. And for those who joined a little bit later, Dr. Keith Smith is speaking today. He's a board-certified anesthesiologist. He also co-founded the Surgery Center of Oklahoma. And in the chat is a link to his website that lists all the prices that he mentioned. And Dr. Smith is also the co-founder of the Free Market Medical Association. So Dr. Smith, if you could speak on the FMMA, I'm sure our students would be happy to learn more about that too.
Okay. So one of the primary self-funded company administrator that we work with is called the Kemper Group. So Jay Kempton founded this company, and he basically administers the self-funded plans for, I don't know how many companies now. He's pretty large now. Jay was getting calls from his competitors asking him, how do you deal with a maverick surgery center like Surgery Center of Oklahoma? How do you process the claims when, they tell you how much it is? Do they just send you an invoice? How does it work? So he was getting a lot of questions. I was getting a lot of hate mail and hate calls because when Jay Kempton's clients realized they could buy a laparoscopic cholecystectomy at my facility for $5,865 instead of $50,000 at the hospital, they wanted all of their employees to come see us. Well, what happened invariably was someone would be scheduled for their gallbladder at a big hospital with a different surgeon. The patient would find out, whoa, if I go to Surgery Center of Oklahoma, I don't have to pay anything because my employer's so happy they're paying the whole bill. And so that surgery would be canceled. And that surgeon would lose the patient, and the hospital would see that case go off of their schedule. So then I started getting hate mail, and surgeons were losing business because they basically weren't doing what we were doing. It was the market at work. So I started telling people, well, I'll teach you how to do this. We're happy to take care of these patients, but this is missional for us. We really kind of want everybody to do this, so the system is just not so sick and bankrupting everyone. So I was getting calls from my competitors, and my response to them shocked them. They really were astonished that I was willing to help them join the movement. Jay Kempton's competitors were also astonished that his response was the very same. He was happy to show them how to join this movement. So one day Jay said, I think we ought to make a run at an association. Let's see if we can form an association and have all the like minds gather and have some speakers. And it was just insanely successful, even the first year. So that's the Free Market Medical Association. It was Jay's vision, and it's very big now. We've had keynote speakers whose names you probably know. Ron Paul has been a keynote. He's a big fan of what we're doing. Steve Forbes was our keynote speaker last year. And we'll have a very exciting announcement, I hope, in the next few days about who our keynote is for our conference coming up this next May. I can't say who it is yet. but it's a TV personality you all know and probably like. So anyhow, that the FMMA is in its, I believe, our 7th year. It's an industry organization that includes physicians, specialty physicians, direct primary care doctors, hospitals, surgery centers, third-party administrators, the people who administer self-funded plans, self-funded employers, stop-loss carriers, think tanks. There are a lot of think tanks that are very interested in these free market ideas because, you know, the largest self-funded employers out there are state governments. So the state of Montana is probably leading the way. Oklahoma did for a while, and then the politics got the best of people here. Now, we had the state government, a self-funded employer, was actually paying 100% of patient surgical bills if they came to my facility, and then the hospitals just put it to death. They threw everything they had to make that stop. But yeah, Montana is going down this road, and I think other states will follow. So yeah, that's the FMMA, and that's there's always a good representation of BRI at our meetings, and we love to see the medical students there.
Thanks, Dr. Smith. And we'll be sure to be on the lookout for the speaker announcement. And we do have a question in the chat. Are there additional ways outside of creating fair competitive prices in a private practice to reduce these crazy high hospital costs, such as for someone working within the hospital?
Really not. You know, there are 3 components for say a surgical bill in a hospital, and those are the institutional charges of the hospital, the professional fees by the physicians involved, and then of course anesthesia on the other end, which are also professional fees. But you know, the hospitals they subscribe to, almost without exception, they subscribe to the economic model in this industry that is all about maximizing revenue. And after the federal government stepped on our neck in 1992 with the resource-based relative value scale, the physicians who kind of were, they were in charge of the hospitals. I mean, if a hospital did not provide what a neurosurgeon needed, then they would go to another hospital who would cater to them. So physicians would go to one hospital instead of another, and it was very competitive. The hospitals had to compete for the internal medicine docs, the pulmonologists, everybody. They had to compete for their patients. And if they didn't provide quality, then the surgeons would just go somewhere else. Internal medicine docs would just go somewhere else. And I saw it countless times just in the 7 years that I worked at hospitals. I saw a lot of that. Once the rise of the administrator class happened, then they were in control of the hospitals, and the physicians no longer were. To make sure their iron fist was completely in control, they hired a lot of physicians. So now these physicians, who are now their employees, they have to do what their employer wants them to do, or they run the risk of not being employed anymore. So if you are a physician inside of a hospital and you're trying to change things, you may get some lip service about, yeah, we'll look at that. But they're totally revenue focused, almost without exception. And the only thing they might respond to if you are extremely busy in private practice is you're threatening to leave. But most hospitals now are trying to discourage private practice independent doctors from even working in their hospital. They don't want to deal with surgeons or internal medicine docs or anybody that has any leverage. The last thing they want to do is have to respond in a healthy, competitive way to the demands of a physician. So I would say a physician kind of working within the system is wasting their time. That's why I decided I have to have control of my own institution. And there are physicians who own their own hospitals or own a portion of a hospital, so they at least have a say. But in a hospital where there is no physician ownership, then there's no accountability to the physicians, and the administrators do whatever they do that they can make the most money.
Thank you, Dr. Smith. There is another question in the chat. For other groups and practices trying to replicate this model, do you think there is any limit to their scaling to the size of hospitals, either in volume or severity of disease?
I really don't. I don't think there is any limit. And the reason I say that is, up until about 1961, the vast majority of hospitals in the United States were established by, owned, and controlled by the doctors who worked there. That was a long time ago, but that's the way it was. I mean, my great uncle was a guy named Walter Bays. He was a great man. He was a great doctor, and he worked in a town in southwest Oklahoma. And the ground floor of his house was his clinic and the town hospital. And he lived upstairs. And when it got too busy, he built a hospital. The old timers in Chickasha, Oklahoma still call it Bays Hospital, even though it's no longer a hospital. But that was the case all over the United States. The physicians owned and controlled the institution. They owned and controlled the facility. There was never a situation where a patient would say, man, this hospital bill's crazy. And the doctor says, there's nothing I can do about that. That's the hospital. That's a relatively new phenomenon. Dr. Bays, my great uncle, could just not charge anything if he wanted to because it was his hospital, or he could charge him whatever he thought was fair. So anyhow, it is scalable because that's where we started. As physicians, that's where we started, was owning and controlling the entire spectrum of the care that patients received. It started to change, though, when the idiot Harry Truman passed a law that put community hospitals all over the United States. And that meant there were all these hospitals that showed up, whether there was any market for them or not, and they're competing right across the street with physician-owned hospitals. And then to feed those hospitals in the early 60s, Medicare, the disaster of Medicare, was foisted on us. So, these hospitals could then plug directly into the taxpayer trough and drain the coffers. So, everybody on this call, I hope, understands that if you've ever had a paycheck and you saw Medicare came out of that paycheck, that's not being put back for you. Same as Social Security. That money is being paid to someone who's a current beneficiary of that robbery out of your paycheck, and that's a Ponzi scheme. And this whole thing is a scheme, and the federal government's to blame for it. But I think that in spite of the efforts of the government, this effort is scaling and it is growing, and that's astonishing to me. It really is remarkable that this free market movement even exists, but that it is growing is completely astonishing.
I think it has a huge attraction, given that through the free market system, we're able to preserve the sanctity of the doctor-patient relationship, and doctors are actually able to practice the way they want to practice and offer more affordable and high-quality care. There are a few more questions in the chat. Are there trends of types of hospitals that are encouraging this type of market? And do you have any predictions and recommendations to get leverage for those specialties that don't have the same level of control?
Yeah, that's a good question. Cardiac hospitals, orthopedic hospitals are a great fit for this. If someone wanted to start an ear, nose, and throat hospital, that would be a great fit. So those types of fields are even a gynecological facility with a birthing unit. Those types of specialties are a perfect fit for this. And of course, they all need anesthesia. So, there would be anesthesiologists involved and pain medicine. So yeah, there are fields and specialties and subspecialties where doesn't seem like it's quite as natural of a fit. I know rheumatologists and neurologists now who are embracing, and pediatricians who are embracing the subscription model that's now become popularized by the government. So in your nephrologists, these are people that have a panel of patients that are repeat customers. I mean, they're coming back all the time to get endocrinologists, with patients that have diabetes. These patients need to be monitored. They need to be seen regularly. So it's perfect for a subscription type of practice. But, every day that goes by, there's less and less that we need these price gouging hospitals for. Hospitals definitely have their place, but they do not need to be calling the shots. And you do not need your bunion removed in a hospital. And increasingly, you don't need very much of anything done in a hospital that is a surgical procedure. Hospitals are for sick patients. They are not supposed to be these revenue machines. So I think as time goes by, more and more we'll see that subspecialties that are not a great fit for outside of the hospital type of practice will become even more so. We have pediatric surgeons coming from the Children's Hospital here in Oklahoma City working at our place, and they're doing procedures as an outpatient that, when I came out of training in 1990, I just cannot imagine a 4-month-old for a bilateral inguinal hernia repair, and they go home the same day. And we did that here not that long ago, and you just think, those were cases that were inpatient cases, and increasingly they're not. A friend of mine has it's licensed as a surgery center, and it is a cath lab where they put in stents, they put in pacemakers, they're doing endovascular treatment of aneurysms. I mean, you just think this kind of technology, you said that was going to be the case back in the early 90s, that you'd be institutionalized. So it's very dynamic, it's changing, and I would say, if someone is wanting to pursue a career in what is normally a hospital-based or like a real Medicare-heavy population, they should give some thought to a subscription model, and I think they'd be wildly successful.
Awesome. Thank you, Dr. Smith. We have another comment in the chat. If you'd like to unmute yourself and share, go ahead. Otherwise, I can read it for you. So Luke says, I remember listening to you on Russ Roberts' show, Econ Talk, about 2 years ago. You have a great story with incredible insight into the insanity of pricing in our current healthcare system. Thank you for what you do. And the question is, approximately what percentage of your patients are uninsured versus insured, but still go to the Surgery Center of Oklahoma since it is less expensive than using insurance through a local hospital?
Good question, and thank you for your kind words. Russ Roberts' interview on Econ Talk was one of the more enjoyable interviews. He's so knowledgeable, and he had done his homework, so I really enjoyed that interview. And I think he was, if you listen to it at the end, I think he was really affected emotionally by what we were doing, because he's been preaching free market healthcare for a long time, and we were an example of someone that was actually doing it. So That's a good interview. I'm glad you heard that one. The percentage of, let me define uninsured, people who have no insurance whatsoever, that's about 30 or 35% of what we do here. But there are people who I would call, let's call them underinsured, for lack of a better word. I don't actually like that word. But if someone has one of these silly Obamacare ACA policies that has a $7,500 deductible with a $10,000 family limit, and they see that their child can have their adenoids taken out at our facility for $2,850, then they are paying us upfront. They're paying us cash, just like someone who's uninsured. So in a way, I would say even some people who have an insurance card in their pocket are basically uninsured, because these deductibles are such huge hurdles for the average American family. They're functionally uninsured. People that belong to health sharing ministries, technically they're uninsured. I mean, they pay us and then the sharing reimburses them above their sharing amount. It's just straight uninsured. The answer to your question, on any given week or any given month, is between 30, 35% of our patients.
Awesome. We actually do still have a few more questions. I know that we're approaching the end of the hour, but hopefully people can still stay on. Dr. Smith, could you briefly compare your surgery center to the Canadian healthcare system?
We are the best thing that ever happened to the Canadian healthcare system, and the Canadian healthcare system is one of the best things that ever happened to the Surgery Center of Oklahoma. I used to make fun of them and just how awful they were, and I had some of my partners here have told me to stop, because the Canadian healthcare system has sent us a lot of business, and you typically don't run down the source of your referrals. So they are opposites is the answer to that question. I mean, the Canadian healthcare system is one where government bureaucrats serve the role of rationers. So they get to decide who gets what, who gets it when, and they're always wrong. Central planning like that does not work. You can read Hayek's Road to Serfdom, and you get a feel for central planning and why it doesn't work. If you really want to get into that, you can read Ludwig von Mises' book, Socialism, where he really gets in the weeds on why central planning cannot possibly work. So the Canadian central planners decide this is how many total knees are going to be performed in a year. This is how many hysterectomies are going to be performed. And then they run out of money, because if you're a Canadian, it's free. I mean, it feels free. Of course, it's not free, because the taxes they pay to support this disaster are incredibly high. Surgery Center of Oklahoma is very different. I mean, we say, here's what we do, here's how much it is. And when a Canadian calls, the first question they ask is, how long will I have to wait? And when we tell them there is no wait, they really can't wrap their minds around that. And a friend of mine who lives in Canada says, the old joke is a Canadian is never truly happy unless they're standing in line. And so the Canadians really don't know, they don't understand that as soon as they get here, we can get them taken care of. So we are affordable, we're available, we're fast, it's high quality. I would say the care in Canada that is rendered is high quality. It's just not available. And when you add up all the money that they throw at that system, it is unaffordable. It's incredible. All of these provinces run out of money and are begging for money from the home office every year. And then people are in waiting lines 2-3 years for a hysterectomy. And the woman's having transfusions all this while, and usually they get sick of that and they pay $8,000 and come down to our place, all in, have a laparoscopic assisted vaginal hysterectomy, and they're in their nightmare.
Oh, thank you for sharing that and for your honesty. And also thank you so much for the reading recommendations. Be sure to jot that down.
Welcome.
So in the audience, we have mainly second-year medical students, a few first-year students as well. And I know that many students are considering anesthesiology as a profession. Do you have any recommendations for those students in particular, and also students who are wanting to do private practice after medical school?
Anesthesia is fun. I still love anesthesia, and particularly for me, the pediatric part of my practice. But anesthesia is fun. The anesthesiologists in the United States, as a group, have more effectively resisted hospital employment than many of the other specialties. I think radiologists have done a pretty good job. The ER doctors have done a pretty good job. The pathologists hit and miss. But anesthesia as a practice is more likely to be a private practice than almost anything else. So I still think it's a great choice. If somebody's interested in pain medicine, then they can be in control of your schedule and not have surgeons be in control of your schedule. I would do anesthesia again. It's been a great field, and it's a lot of fun. It's interesting, and there's always something new coming along. The pain management with ultrasound is so exciting and so much fun. I would encourage everyone on this call, regardless what field you're considering, to resist the lure of hospital employment. If you hear one thing I've said, you really need to resist that. There's a dilemma that we'll face, that any doctor who becomes a hospital employee will face, that no doctor should ever face. And that is, do I do what's good for this patient in front of me, or do I do what my employer wants? If that sounds harsh, let me give you an example that happens every day. Primary care doctor is employed by a hospital system, and a patient in front of them needs their gallbladder removed. They need a 3-vessel bypass, you name it. If that primary care doctor doesn't refer to the surgeon who is also employed by that hospital, who that primary care doctor also knows is horrible, then that primary care doctor puts their own job at risk. There may be a private practice person across town who is extremely talented and good at one of those procedures, but the primary care doc is prohibited from sending that patient to where the best solution is, and they know that. That is the source of burnout. That is this moral, just complete depredation that occurs that causes burnout, because it's an ethical dilemma no physician should ever face. If you're never a hospital employee, then you can get people to where you think they need to go. If you're a hospital employee, then you're constrained. So I would ask everyone to resist that temptation. And it sounds like a lot of money, but they're not offering you any amount that is more than what they're raking in off of your hard work. If you're thinking about a primary care specialty, direct primary care is a great way to start. There are plenty of direct primary care practices out there that are looking really hard for kind of free market-minded, hard-working young people like yourselves. If you're looking at anesthesia, you can join a group that'll have some kind of a guarantee for you, and you work for a while and then you become a partner. There will be a lot of opportunities out there in areas that are underserved where you really can work for yourself from day one. Just make a decision grid and look at all these things and weigh whatever the factors are that you feel like you need to consider. But anesthesia is a great choice, but I think you can go into private practice in the United States in almost any field without becoming a hospital employee. So I would ask you all to look at that with a very jaundiced eye.
Awesome. Thank you so much for your words of wisdom. And it's certainly inspiring to know that the future of healthcare is definitely a free market one, and that we can start now and be more informed about it. And I did post an attendance survey in the chat. We would love it if you guys could fill it out and offer us some feedback about today's talk, and also ask further questions of Dr. Keith Smith. And if this is the first time that you've attended a BRI event, please feel free to reach out. We'd love to hear from you and get in touch. But we at BRI believe that we can be better stewards of health freedom and meet these healthcare challenges that Dr. Keith Smith mentioned today by just getting a better understanding of free market economics. And so it definitely starts with us. Thank you all so much for attending. Any questions, please feel free to follow up with us.